Good morning and welcome from all around the world to Structural Half-Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist and a professor of medicine. I will be your moderator today. Remember, this is a very interactive experience. We'd love to hear from you, so please send us your question directly from the website or from YouTube. And today you will be available to review this case and all our previous cases in our website at ccclivecases.org. We have an incredible case, and let me put you directly to the cath lab for the case.
All right, good morning to all our viewers, and of course, Pedro, thank you. With our team here, myself, Dr. Keeney, Dr. Khera, and Dr. Gilbert, and rest of our fellows crew, and Dr. Lucy Safi as echocardiographer. Very interesting in the sense this is a kind of case, we'll be doing it first. But and that is the Evoque valve, since it started last April, March, April, has really taken off in the country, and we are also very happy. But what is happening is for last 2 years actually, we are using the Evoque, which is TTVR. Some issues, while it is very effective, safety in terms of halt and some time pacemaker and bleeding, all those issues I'll discuss in my didactic discussion. But this case has a degeneration of the Evoque valve in just about 2 years. And now we are going to use a SAPIEN to take care of that valve degeneration, and that degeneration is because of halt. So very unusual. Have you done any case of this type? This will be the...
Yeah, I think live would be the first.
Live, but we have done one case, so let's go to our presentation with that note, these are all faculty involved and with their disclosures. Our cardiac anesthesiologist is Dr. Eric Fried, and rest is unchanged. So what planned today is transcatheter tricuspid valve-in-valve replacement using 29 millimeter SAPIEN Resilia valve in failed Evoque valve. So that's the plan. This is our episode number 79. As you know, with the CCC Live, we just did 200th case 2 weeks ago. And this patient is a 77-year-old, has presented in recurrent symptoms after the initial procedure done in 24. Patient has multiple comorbid conditions, which are shown here, and originally had a reduced heart failure, largely because of the chemotherapy used for lymphoma and others, and has a pulmonary hypertension with a severe TR. Then patient has, after heart team discussion in 24, underwent TTVR with 44 millimeter Evoque valve, and then now discharged on apixaban, clopidogrel, and that time was discharged. Then patient actually require various surgical procedure for the port because of the chemotherapy, and anticoagulation was interrupted multiple times. Then patient start having symptomatic with a dyspnea and leg edema. And then we did the echo, felt there was some halt, restricted valve motion, so now changed to rivaroxaban, originally was apixaban. Now, good medical therapy, as you can see there. Patient has first AV block, right heart pressures were done, which are kind of just mildly elevated pressures, not much. And the TTE, which was done, just showed that some tricuspid gradient of 6 millimeter, as you know, 6 millimeter is very big. For the tricuspid size, mitral is still okay, but tricuspid 6 means you have a moderate plus tricuspid stenosis, and also saw tricuspid leaflet appeared thickened and likely halt related degeneration, and right ventricle appeared dilated with severely decreased function. EF was noted to be 23% with severely dilated left ventricle. Now this patient actually has change in ejection fraction anywhere from 23 to 40%, and I think largely driven by the medical therapy of whether patient taking Entresto and diuretics at that time. So with that note, we should go with a live echo before we proceed further. So Lucy.
Thank you, Dr. Sharma. And here you can see today we evaluated the patient on the table using 3 imaging modalities. So I'm going to start initially with the echo. So this is the transthoracic echo imaging. You can see a focused RV focused view here on the transcatheter valve in the center with mild tricuspid regurgitation that's valvular. There's no paravalvular leak. I also want to point out that there is a significant RV dysfunction in this patient. And we get some quantitative measurements coming up. The LV systolic EF is estimated at around 40% today.
Very good.
Here you can see the TAPSE is significantly reduced, and I'll give you multiple RV parameters. I know that each one of them has its limitations, so this is about 12, considered severely reduced. The S prime was calculated 7.3, less than 9.5, again in the moderate range by the TVAR criteria. We did RV free wall strain, which is also reduced at negative 12.8. We got a tricuspid valve gradient today under general anesthesia with a heart rate of 62. It was in the 2 to 3 range. Oh. And this is all transthoracic imaging. Her tricuspid pulmonary pressure estimate was about in the 30s, low 30s. And then here, this is actually a transthoracic image 3D. And you can appreciate, even on transthoracic 3D, that the anterior and the septal leaflets, which are labeled, are restricted in motion in this view. Now we're going to show you TEE. So this has a significantly dilated right heart with a horizontal heart. So the images were a little shadowed from her prior transcatheter valve, but you can see her RV, again, RV systolic function is significantly reduced with valvular mild tricuspid regurgitation, no PVL. And then for her transgastric images, pretty lovely here. You can see that her posterior leaflet is completely stuck closed from her halt. And then her anterior and septal leaflets shown here, they do open, but with very restricted motion. So this is a degenerated prosthetic valve, despite her multiple anticoagulation. You can see that she has an eccentric anterior directed jet of tricuspid regurgitation, most likely due to that frozen anatomical posterior leaflet. And again, on gastric view here, you can see on 3D the frozen posterior leaflet and the restricted anterior and septal leaflets. And now we're going to show you ICE. So just for completeness, all 3 echo imaging modalities, you can again see the restricted leaflets. So this is the septal leaflet, pretty restricted here, and the anatomical anterior leaflet. Again, that valvular TR. On ICE, her tricuspid gradient was 2. And then again, her ICE 3D here. And you can again appreciate the thickening and the restricting of restricted tricuspid valve leaflets, both with and then without color.
Fantastic. So maybe both Sahil and Gilbert can comment on it. So a lot in the literature from imaging of the tricuspid valve is very difficult, and they say both TEE and ICE are complementary. Are we doing both in every patient?
Yeah, I think that's a great point, Dr. Sharma. You know, the right side of the heart is difficult to image. So TTE is very good for baseline imaging. For these procedures, which are pretty complex, you know, when you're trying to engage these anchors, you may lose visuals during your TE, especially if you have other prostheses in there. So ICE has become very complementary, and we've moved away from, you know, TE only to now TE plus ICE. And in some cases, we actually rely on ICE more in these tricuspids. So I think my preference would be, going forward, they should be ICE predominant procedures rather than TE predominant procedures, just by the proximity of what you're dealing with.
I think that the main thing is that improves safety in terms of, particularly if it's a tricuspid tear procedure in terms of confirmation of insertion, but also in this kind of the TTVR where the mechanism of anchor is leaflet capture. So you don't want more than 2 anchors of the Evoque valve to miss the leaflet, then you can risk paravalvular leak or maybe even canting migration. So ICE is extremely useful. And these patients, remember, like, look at the comorbidities in this patient. Is very sick. We want the procedure to be done safely and efficiently. And Mount Sinai, we have always done ICE since the initial FDA approval for 3D ICE for all our tricuspid interventions. So we are very comfortable doing that. And I think we would encourage the audience out there, if you have access to that, don't be shy, learn this technology, because it's going to be getting better and better, and may even be, to Sahil said, a predominant technology for some of the structural heart procedures.
And actually, that's a very important. Before we started the program with the Evoque, we waited for the ICE to be acquired and learned from the eyes point of view. And Anu, tell us about this patient yours who has now valve already degeneration, has a severe RV dysfunction and dilated, and now we are going to put a valve which is going to increase the afterload. How are we going to, do we manage these patients by bringing them before, or what is the usual story on these cases? How we should be doing more safely and at the same time efficiently also, because you don't want to increase the length of stay of these patients.
They are being seen in the office beforehand, and then I think we bring them 1 day before to make sure they are optimized well, especially with the diuretics. That has to be done. Not for the first, I mean, this is the second time, but when you are doing first time, many of these CT scans, imaging, all that we do after 24 to 48 hours of diuretics, because you need a full optimization so that you will get the right sizing of the, especially the Evoque valve.
Because this case now, I mean, although you already have tested that, with that RV dysfunction, patient tolerated Evoque, and now you are going to put an additional valve, so should not be extra strain.
Well, so that's a great point. So Lucy, why don't you tell us, you did some RVPA coupling calculations before and after. Maybe you can comment on that.
I did, actually. So very interestingly, we did have the opportunity to go back even before her initial Evoque to measure her PA-RV coupling. And then right now on the table, we did it again with an invasive measurement of her pressures. And they're pretty similar. They're comparable. So her RV really didn't change too much from even prior to her first Evoque procedure.
Okay. All right. So let's go to slides presentation continues. Okay, so now we have done with our echo, live echo has been done, transesophageal, transthoracic, all has been done, and now we go to our CT angio. So basically we are showing that halt indicated by arrows. So what exactly you see on the CT scan? Those shadows?
Yeah, so you see the thickening, that dark shady leaflets, those are actually leaflet thickening. And you see there are two frames, right? So the inner frame is your actual valve, and that's the outer frame. So all the Evoque valves are 28 millimeters, all of them, irrespective of the sizes. The 44 is the outer housing. So you see that black shaded area between the two frames, that is your outer housing, which is completely thrombosed, and they do thrombose, okay? So it's like the big sinus in a bicuspid with eddy currents and that sort of slow eddies. So it's all thrombosed, and the leaflets are pretty thickened. So I would call it halt degeneration here.
Now, let's say on the CT, if it was not the halt, how would that look, those two shadows? In between would have been a gray rather than black, or what?
Well, even if there is no halt on the leaflets, that can still look black.
I see, okay.
But
Because
it's not
there's stasis
thick.
of blood.
The thickness is the key.
The thickness of the leaflets.
would be like, you would see it. We published this actually. We were the first to publish in JACC intervention the frame geometry of Evoque valves. And we can see the various degrees of halt and thickening leaflets. Some of them have no thickening at all, actually. But in this case, you do. You can see it here.
So this is, yeah, sorry.
I know we used NOAC, DOAC here. Was there any reason to have tried with the Coumadin?
Yeah, so she has had a very hard time with Coumadin. When patients are very frail, there are a lot of dietary restrictions on them with Coumadin, and it's hard to maintain their levels. So she would go from 7 to 1. There was a lot of variability in her Coumadin regimen and dosing, so it was very hard to manage. Initial treatment was Eliquis and Plavix, and then we gave full dose rivaroxaban. So 2 NOACs, including an antiplatelet, has been tried, but it's been hard. But I think Coumadin, if patients can tolerate and they can manage their INRs, would be the best thing to do.
Okay, so let's talk about what happened in the Transcend trial, or when we did the TTVR with Evoque. What is our anti-thrombotic regime? One is anticoagulation, because 80% will need it anyway because they are in AFib. But otherwise, what else? Everybody get clopidogrel or what?
Aspirin.
Aspirin?
I mean, in the trial, there was no definite indication, but we give aspirin.
But this patient here was discharged on Eliquis plus clopidogrel.
Yes. So
but the patient no CAD.
No CAD, no. So I like, so if you look at the trial data, the 30 days, right? So there's no lifelong anticoagulation mandate
right
for the trial. But when we pre-screen our patients at Mount Sinai, what we do is we make sure they can tolerate as long as possible, because we don't know about lifetime for anyone, but we know as long as possible if they can tolerate anticoagulation. If they cannot, then we do not screen them for TTVR.
That's a very, very important point, Pedro. We need to emphasize on that. So many times, clearly we know that TTVR is the ultimate frontier. That's what you do, because you eliminated both regurgitation and the gradient. But many of them are not suitable for TTVR, not because of the anatomical, but clinical, that cannot tolerate or long-term oral anticoagulation. Because they say 15% of these patients have cirrhosis. And they will bleed to death by even small, and that is one of the big factor of follow-up these cases. So if patient cannot tolerate oral anticoagulation, our inclination has been to go to the TR rather than TTVR.
Yeah, no, I agree with you, Dr. Sharma. I mean, if you look at the TRISCEND-2 data, the bleeding complications, some of them were non-device related, like a GI bleed and others. So I think that is not benign, and a lot, remember these patients have portal hypertension, maybe even esophageal varices and others. So I think it's very important to have that discussion up front.
And long-term data, if you compare aspirin versus clopidogrel, all have shown the clopidogrel is more GI safe compared to aspirin. GI side effect, bleeding, ulcer is on much higher with the aspirin versus clopidogrel. So I would say in these cases, when we are giving anticoagulation, you want to give clopidogrel also, or an antiplatelet therapy, probably clopidogrel should be favored rather than others. So just to sum it up, this is the patient, we are ready now. After heart team discussion, considered to be a high risk for valve replacement. Of course, even first time was high risk, and now transfemoral TTVR, the valve in valve, we are going to put a 29 millimeter SAPIEN-3 Ultra Resilia valve in the degenerated 44 millimeter Evoque valve. So tell us what you are done now, Anu, so far. Where are we?
So if you can see here, we'll go. Okay, that's the ice catheter, right? Did we show the ice, right?
We
showed that. Good. So we will have to cross this valve, which will be using Agilis, right? We'll cross the valve, and we'll use a pacing wire in the RV. We will have to pace when we are replacing the SAPIEN valve. So the goal will be, I think we'll just cross and then place the SAPIEN valve. We don't need to pre-dilate. So we're going with the Agilis now, okay? Heparin has been given, ACT is close to 290.
Give me the rail.
Yeah.
So Gilbert, although I didn't find much on the data of the SAPIEN and the TTVR Evoque degeneration, but question is, we know this case is not a concern because it's already 1.5 to 2 year time frame. But if somebody comes back with a halt within 2-3 months and you really need to put a SAPIEN through, would you be worried about embolization of the Evoque?
Yeah, no,
it's not been fully endothelialized with only 2-3 months.
Yeah, no, that's a great point, Dr. Sharma. I think you do have to be very mindful, and that's why I think multimodality imaging is key. I don't think you can say, it is a fluoroscopic guided deployment, but you have to be very careful not to interfere with the stress. Actually, we didn't show this on the post-CT scan, the inflow of the Evoque valve. On the outer frame where it couples, it's actually 23 millimeters.
Okay.
It's not 29. The inner valve is 28. So you have to be very careful about getting caught when you pass the SAPIEN valve, because the SAPIEN valve is not protected. There's no capsule, so you have to be. That's why it's very important to you use imaging to be able to see whether it tracks properly. And I agree with you that because the way the valve is anchored, you don't want to push the valve towards in the ventricular side.
Okay.
So we have a J wire, but more important, we are going with the multi-purpose. You saw the Agilis already facing there. We'll go with the multi-purpose. Okay, and I'm going to undo a little bit. Yeah. You see that? Very nice. That way.
Pull back a little more.
So let us see. Now go with the
pull back the Agilis a little.
Yes. So we'll rotate it a little bit. Yes.
Now bring the multi down.
Advance the multi-purpose.
Show a little more of the ventricle body.
Now you can push the.
Anything special technique needed to rotate or clockwise, counterclock or anything or no?
Nothing. No clock, counter clock.
But your wire is not at the apex yet, right?
Yeah.
Okay. caught between the
No, yeah, it could be the restricted
Chordae?
leaflet.
Yeah.
Let me
or
see.
chordae?
Yeah,
No?
so let me
So the other
advance.
thing is maybe go a little deeper, yeah, and then point it down because it's pointing towards the RVOT, which sometimes happens, and
Maybe we can go with the pigtail now.
No, we can ask Lucy. What do you think? Where this catheter is stuck somewhere, Lucy, in your TE or
Yep.
ice, whatever it is?
So
so
I'm trying,
another
yep.
trick
Okay,
we
now-
can
now we are
use,
good.
yeah.
Okay,
So we
clear
can
now.
just push
Yeah,
the
so advanced it nicely.
all the
And
No.
we request all the audience to ask
close
any
like that.
questions because this is something very
Close it.
atypical,
Yeah, I did.
very rarely seen, and we
wanna swap to a
we
pigtail.
collected our strength or courage to show that case live.
Unbelievable. We actually have the first question. Can we see a chest X-ray?
Oh, chest X-ray.
Just X-ray.
On what? For
We
what?
don't know where to
Yeah.
get it.
I don't know why.
No,
I
you
agree
cannot
with
see
you.
tissue on chest X-ray.
No, we can
Okay.
make a quick slide on the backside.
You know, but
Yeah.
that's
Safari?
so
Yeah.
CT is the only
Yeah,
way
yeah,
to
yeah,
see
yeah.
the leaflet
Yeah,
degeneration
facing.
how even MRI
Safari.
because the
Facing
frame
one.
is
We'll
so dense that it might be difficult. So,
Go
but
slower
that's
because
a
we
so
need
but
to talk
X-ray
about
can
it.
obviously see the position of the valve,
Pigtail nice.
just like
We can
fluoroscopy.
pull a chest X-ray
But
to the slide.
but you need CT scan to
you
be able
took
to
the
see
wire
what
out.
happened.
I thought you want to go with this.
No, we
Thank you
need
for the
300 wire
question.
for the long pigtail.
Go.
And leave it.
Now push it out. Just push it out.
No, I won't do that.
Okay.
Okay.
Give me
Get
the
us
long. Go swap
We
for a
were
pigtail.
trying to cut down a step, but I guess we need it. We're going to put a
Pigtail?
pigtail. Yeah.
Yeah.
Never cut short. No, this is a long wire.
Yeah.
Okay. And then get us a pigtail. Long
So
pigtail.
coming along of these Evoque failures, the only therapy will be the SAPIEN. Is that a correct statement?
Yes.
Yes.
Yeah.
You know, we don't know how much of this is, failure or just the natural process that happens on the right side, right? So the device is intended to do what it's doing. Push the
No,
wire, push.
don't-
Oh,
Ay.
oh.
So
Keep
can
an
we get back
eye.
in?
Yep. Yeah, you were saying we want this to last more than 2 years, huh?
No, we want them to last longer, but sometimes it's the protoplasm, right? Some of these
Actually, I
patients are
was,
sicker.
The wrong pigtail.
While we
Don't
around,
worry, it's a
while we
small patient.
recross, definitely patients with previous radiation had a much higher MACE than patients without previous radiation, and it can go to up to 30% mortality in 2 years.
Good.
So this is what you're saying, Sahil, is absolutely correct. This patient is a high risk no matter what.
Well, I mean, anyone, like you said, with cancer, even for TAVR, right, Dr.
Yeah.
Moreno?
Yep.
You leave this wire, and
Radiation-related
then
heart
swap for the picture.
disease are very hard to treat, as you know, in the native state. There are a lot of fibrosis, even potential early degeneration. We see some of those patients as well in TAVR. And this is now the right side of the system, so that's even more vulnerable to potential early degeneration. And, in surgical tricuspid valve replacement, for example, that, we typically mandate 3 months of warfarin, right, per guidelines.
Yes.
So then these are bioprosthetic valves. So I think, and when sometimes we even maybe increase the iron out threshold a little bit more. I mean, as you know, mechanical valves obviously much higher on the tricuspid side, but even bioprosthetic valves. So I think, these patients who are vulnerable to
Don't pull anything.
anticoagulation
This is long.
regimen would be challenging.
Very good point. So,
So,
anticipating potential issues in this will be really perfect positioning,
Yeah, so
embolization.
couple of things, Dr. Moreno. So first, let's talk about the tissue. So the Evoque valve right now is not Resilia tissue, the one that is approved. The next generation will be. And so that's why we think that maybe the Resilia tissue, given the, so far, at least in the aortic side, has very good durability on the surgical AVRs, that we think that hopefully will help this patient as well. from a longevity standpoint, we don't know the answer to that, but still, that's all we can do, because I can tell you that some of my colleagues who have explanted these Evoque valves, it's a Herculean effort because if you look at the design here, the anchors are on the ventricular side, and it's bigger. So it's very hard to compress and deform this valve, even though it's nitinol based, because the metallic radial force is so high. This valve was designed initially for mitral, not tricuspid. So to take this out surgically will be extremely, extremely difficult. So that's why I think that for this particular option is really the only option for this patient.
Don't worry, got it.
Yeah, the tear will not be an option as discussed.
No, wait for me.
Let me force
No,
it.
tear will not be, because it's in this particular case, because thickening of the leaflets, and there is already a gradient.
Yes.
6 millimeter, although the valve with the anesthesia, under anesthesia is only 2 or 3.
1 second.
And it's a thrombotic, valve. Some clot has been made with the halt. So what are we doing now?
We are removing the agilus.
Okay.
First we removed the pigtail.
Okay.
Remember, with the pigtail we have put the left the safari there. Now we are taking the agilus out.
I see.
Can you flush this sheath?
Agilus has been okay. If the chest X-ray has been come, can we show that chest X-ray? Because one of our viewer wanted to see chest X-ray. We have it. Maybe start doing next time presentation. Put a chest X-ray also.
Okay, so we're going to MAC out now to show the E sheath, and we want to flush the sheath. ACT is good. We typically, these procedures like to be over 300 because of the venous side, especially for these patients who are prothrombotic already. 250 usually is sufficient for the aortic side, for arterial side, but I think this is beneficial.
Valve, please.
Yes. So we're going to go 29 plus 3, okay? Because the inner valve, even though it's 20, we need some radial force, but also, like I said, the initial atrial side is 23. And it's, these valves have a pretty high radial strength. So
reverse orientation confirmed.
Okay, make sure that, the valve is loaded proper orientation. So it's, the skirt is going to be on the atrial side, okay? So it's the opposite of TAVR. Very important here.
Good. Stop. Okay, go ahead.
So it's important to maintain the rail here that Sahil and Dr. Kini are doing. And so I'm going to flow safe once the valve is now exited the sheath.
Give me dry gauze.
Yeah, here.
Show you down.
No, it's a lot of runway outside. It's a small patient, right? So it takes time.
So, question: what wire was used to cross the valve? 035?
Initially was
Go in a little further.
035J wire, and
Little
then
further.
now we have the safari.
Little further.
Yeah.
Good. Stop. Pull the sheet back.
035.
Let me flow save that.
And then the safari. Change with the pigtail.
Wait. Let me bring it out.
Now it's the safari.
You can pull the sheet back more.
Sheath back.
Implant.
Good. Little more.
Okay,
Good.
let me
Stop.
flow save that, please.
Okay. Come on.
Yeah.
The audience also want to see
the
the
wire slightly.
EKG.
Yeah.
Okay. Show the hemodynamic on the bottom,
Push the
please.
wire.
Yeah.
Advanced wire. Who
I
has
am.
the wire?
I am.
Good, don't lose
See,
it.
you don't want to buckle though, right? So.
Concentration
Ma-
here while
magnify.
the
Can
question
you-
comes.
Yeah.
Okay, good.
Sizing the valve.
Can I
How
take
do
the
we
floor?
size the
Can I-
valve?
Can I take the floor?
Okay, can we just focus right now?
Okay.
Yeah, I'll tell you about the sizing in 2 minutes.
One moment, Dr. Warren. This is the critical part, okay?
Go ahead. Go ahead. Go ahead. Go ahead. Go ahead.
No, more flex, more
Go ahead.
flex, more flex,
Go
more
ahead.
flex, more
Go ahead. Go ahead.
flex.
Good.
more.
Go ahead.
Flow save that. Good.
Little
Perfect.
more. Good job.
No, not done.
Yeah. Fluoro save that.
Yep. Okay, good.
And we don't measure any blood pressure.
Nothing, Dr. Sharma. No.
Okay.
No, anesthesia has
Good.
it
I see.
on their side.
Now give me my clamp for the electrode.
Can you show the ceiling camera, because we are going to do the pacing?
Now we have the ceiling
the
camera
line.
right there.
Can you focus?
Yeah.
More?
We did in the back. Okay. You can actually attach. And there's one, you can see the anode and the cathode. If you want to show it. So this is how you connect if you want to pace your wire. So that's your grounding.
Let me hold this. It's deep.
Yeah.
We are doing the
We can
pacing
fix it. Just
to
first
that
connect them.
wire that is in
Okay.
the LV. So that you have
Connect it? Okay.
one lead
Are you
that
good?
is here on
No
the
one
left
touched that,
groin,
okay?
and the other lead is
Let's
connected.
test
Yeah.
it first.
Explain again.
So if you can see here,
We don't see your hands.
so this is the electrode, okay?
Okay, we see the electrode. Yeah.
Yeah, so remember, black to back. So this is the end of your safari, black to back. And then there is a needle which is inside the skin. To the tip of the needle, we have connected red. The red of the electrode, red ahead. So red has to be connected to the grounding or the skin. You see that needle?
Yeah.
Yeah,
So
we see
red,
it.
red ahead, black to back. Okay? You won't forget.
Okay, now we'll pull back a little bit.
Yeah.
No, one more, let me
See-
push the wire.
So the
Because then you're already coaxial. So
upper end of the SAPIEN valve should be
Good,
at
that's
the
good.
level of the atrial part of the
Pace 150.
Evoque valve.
Disconnect. Disconnect. Good. Okay. I think we're ready to take it.
I'm going
Looks
in
good.
a little bit.
No, don't go ventricular.
Okay, okay,
Okay.
fine.
We have to file.
So we want to land atrial to atrial. Pace 150.
Yeah, test it first. Don't
We
go up
tested
yet.
already.
We did.
No,
Just
no,
now we
I
did.
don't
Yeah.
know. Okay, go. Okay, go.
No. No.
Yeah.
To be slower. Have to be slower.
Slower.
Have to be slower. And I'll explain why. Nailed it.
Okay, I need to save that.
Yeah.
I didn't see that.
And backup pacing now. Resuscitate.
Yeah.
Good.
No, so leave it there. Leave it there.
Leave it there.
Yeah.
How's the blood pressure?
Go second time.
Excellent. So you saw atrial to atrial have to be very slow deployment here.
Go.
Dr. Moreno,
Yeah.
Go.
let's
go
do one
ahead.
more.
Yeah.
Yeah, we don't see the pressure.
No,
I'll show you.
They don't have.
No, I
Pace
don't have the
150.
pace.
But always should have a
Oh.
4 French, arterial
Okay.
sheath.
Yeah.
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 Keep going.
But you also know that the pacemaker is doing a job.
Now full. It's not full. Expanded. Did we need more?
No.
No, we already-
No. Oversized.
We already plus 3 cc.
Keep pacing. And go back up, please. Back up.
Careful.
Good.
Careful.
Yeah,
Deflate.
careful.
Fully deflate.
No. Get this.
I would take some more. It's getting so let's
Okay,
make
now
sure.
you can ask your questions, Dr. Moreno.
Yeah, we
Now
have
let's
several.
look at the echo. Hold on 1 second. Let's check the echo.
All right, go back to the echo now.
Let's get a pigtail as well.
Empty syringe.
And just for the audience, the BP from
Big
the
one.
anesthesia is good?
Yes.
I think we should be showing 5 French all the time.
Let's walk it out first.
Looks good
Okay,
on
get me a
echo.
pigtail. Okay, good. Stay here.
We see
Yeah, blood pressure is good by our anesthesia team, and this is the
Let's see the
echo.
echo. Let's see the echo.
Yep, so this is echo.
Hold
So
the
you can
sheet
see
up
the
in.
valve and valve. This is the tricuspid valve here. This is the aortic valve at 5 o'clock. When you turn on color, there's 0 leak. Looks
Beautiful.
gorgeous.
Beautiful result.
Yeah, looks
Let us
really
see
good.
the
Shows the
RV.
leaflet. Shows
Wow.
the leaflet.
Absolutely, yeah.
Are we going to improve or decrease?
Yeah.
Yeah, it
Because
should be
it's so-
some stunning, no? Is
Yeah.
that-
No, not only that. Now you increase the afterload
Yeah.
tremendously with a
Yeah, I
failing
mean-
right ventricle.
Visually, it doesn't look unchanged. It looks
No,
unchanged.
unchanged.
Yeah, it looks
RV is unchanged.
No, in this case, I would say it's a little different because you already have tested this 1.5 years ago with the Evoque.
Correct.
Yeah.
And the PA pressures were okay, yeah? From the beginning?
Earlier, but no,
Yes, they
they are
were.
normal.
Yeah.
They
near
were
normal.
calculated.
Yeah.
Yep,
Severe
33.
TR, but 33. Beautiful.
Excellent.
Okay, let's go with questions unless the
Yeah.
operators...
So sizing. You want to talk about sizing quickly?
Yeah.
So the inner housing is 28. The valve, all sizes, 44, 48, 52, 56 are designed to house a 29 SAPIEN. So the inner housing is 28 millimeters for all the valves.
Excellent. That make it simple. Everything
Correct.
is the same. Could you explain how to implant the valve and its alignment? Any specific view for implantation?
Yes. So you see this picture? So you want to be coaxial without any parallax in an RAO view with your initial valve. And then your sapien that goes inside has to land atrial to atrial. So inflow to inflow. You have to match the inflow to inflow because the Evoque leaflets are actually towards the atrial side, not really towards the ventricular side.
So show it here exactly what you mean. Here, right? No, this is the one. This is the one you need to start.
So you see we are starting atrial to atrial. You see how we line up atrial to atrial? An extremely slow deployment. There's no rush. It's tricuspid. Nothing will happen. Take your time. You can adjust, push, pull your wire, push your system down, but has to be very slow deployment and land atrial to atrial.
Basically, no,
I think this is important. We didn't force. I want to follow save that because this is the same as what we've seen in another case where. Remember, for the sapien valve, typically foreshortened from the atrial side, this one did not. This one, in fact, foreshortened from the ventricular side. You see the balloon inflates more. We didn't have that recorded, but actually seeing that the whole S3 the atrial side didn't really move. That's why Sahil said atrial to atrial. And you can see everything foreshortened from the ventricular side, and the atrial only foreshortened a little bit. So very important when you position this valve, not to be too atrial.
I see.
Because otherwise you might end up risking potential migration. So I think this is very important. That's why they call atrial. But when you find adjustment, again, the inflow of that Evoque is only 23 millimeter. You want the S3 to be expanded well beyond that.
And so basically what you did in this view is the top of your sapien valve is at the top of the same parallel, same of the upper part of the Evoque.
Yes, correct.
For people to understand.
Yes.
Very nice. What about the pacing rate? That was partially explained by Sahil. Go ahead again.
Yeah, 180.
No, yeah, so we paced actually. So we paced slower this time because remember the RV is not very pulsatile to begin with, right? So if you're doing TTVRs, regular TTVRs, we don't even pace. But this one, we really wanted to land atrial to atrial. That was our goal. So we paced a little bit. I think 120 to 140 is more than enough to give you enough time to land where you want to be. The margin of error is smaller.
Fantastic. When would you consider a balloon like a BMV?
If it's stenotic degeneration, severe stenotic degeneration.
Very good. Yeah. And what about CRT for this RV dysfunction?
Yeah, CRT for RV dysfunction is, I don't think we do it. This patient had LV dysfunction, but after TTVR and medical therapy, the LV function actually improved, so we didn't consider CRT in that time.
Yeah, but, so it went up to 40 plus.
Yeah.
And now if it goes down, I think this is a good case for CRT. And many of time, actually, in the algorithm, which I'm going to show, they want a CRT first, evaluate your TR, and then you go to management of the TR.
Excellent.
You want to show RV systolic pressure here?
Show the hemodynamics again, please.
So RV systolic is 81.
Wow.
So that tells you that a patient has pulmonary hypertension to begin with, but also that the RV is pulsatile. The RV is generating enough systolic force to sustain itself.
And do we have a gradient?
Right.
Yeah, Lucy.
We can do the gradient. We can remove the ice catheter and do a gradient if you want.
The gradient by T is only 1.
Okay, no need.
Gradient is 1 by echo.
1 by T, yep.
Okay. All right, now tell us to conclude and then we go didactic discussion to finish in time. Yeah. So what is the next step now?
I just want to show some ice images if that's okay.
Yeah.
They did already.
Let's take the pigtail out first.
We didn't do ice.
Post ice.
Let's take the pigtail out first. You want to do that? You don't need it.
No, it's okay. It's okay.
It's just better in images.
Here. Look at the quality of imaging. That's what I want to show, that ice is really helpful on the tricuspid side.
Beautiful.
Yeah,
Lucy,
and when you have an RV failing, would you consider a PA catheter? Is it immediately after or something if patient needs a lot of inotropes or?
You know, Dr. Moreno, PA catheters are very good, but we have such good imaging now with echo and ice and unless patient is in fluid RV failure, I don't really think you need a PA catheter. You support the RV for a couple of days and then
anesthesia.
And then patients usually go home.
What is no, I know. What are you giving for RV right now?
Right now, a little bit of epi, low dose.
No.
Yeah.
Epi and?
0.03 and Novenon 0.25.
Oh, 0.25 of milrinone and some epi. Low
Small
dose.
dose, okay.
Yeah.
I'm not sure if they could still see. This is 3D ice. Look how beautiful this is.
Yeah,
I
look
really
at that.
appreciate it.
Fantastic.
Very nice.
Whoa.
And with color
Okay.
even. Yep.
Start.
Good.
All right. So now
Okay,
next step, you have to take your pigtail out.
I'll take the ice out,
Okay.
and then we'll give some gradients to Dr. Moreno. He wanted some gradients.
Okay.
That's okay.
No, no,
So,
let's-
yeah, we have time for your class, huh, Dr. Sharma?
Yeah. Let's
And
just
meanwhile,
start
show the
shooting.
chest X-ray also, please. Because once somebody wanted chest X-ray,
Yeah.
we said we got. Look at that
Yeah,
PL
very good.
lateral. Whoa! Look at that X-ray.
Wow, beautiful.
Yeah,
So-
look at
And
the.
you can see the Evoque valve.
So if somebody can educate us, what are we looking at?
Well, the shape of the ventricle in
Yeah.
the PA shows that it's mostly RV.
Right.
And then
RV
you.
and RA dilatation. Look at the RA dilatation.
Yeah.
Yeah. And then in the lateral, you see the percent of the ventricle touching the sternum should be less than a third, and here it looks like about that, no?
About half. Yeah.
Yeah.
All right. So let's go back to our fluoro, please.
And kyphosis.
Yeah.
And
No, but this is done. Just go to active fluoro. Okay. Now here. So you're going to check the gradient first.
yes, I'm going to give some gradients, and then
And then
we can
and you
close the
take
case.
out the pigtail on the wire or just pull it
No, we'll take it
can
on the
take
wire.
We'll
it up.
take it on the wire,
on the wire. Okay.
always.
Okay, now we can do a gradient here, 50 scale, please. Change the scale to 50,
Make sure the
please.
hemodynamic screen, please.
And 0 everything, please.
No, yeah.
It's a little bit of V wave, but nothing, huh? Nothing. The tricuspid valve is working beautifully.
Good. Okay.
Okay.
Now let's see.
Fast
Look
speed.
at that.
And fast paper speed, please.
NG, no gradient.
Oof.
It's minus.
Look at
One.
the
They got it
mean
one.
atrial pressure of 6.
6.
Yeah.
And gradient
Oh
was
my
1, which is
God.
normal. Nothing.
Excellent
Beautiful.
result.
Whoa,
Excellent.
Whoa, whoa,
Yeah,
whoa.
the atrial pressure baseline was 15.
Yeah.
Just to compare.
Okay.
Oh my goodness.
Yeah.
No,
Let's
no.
put a wire, take that out so we go to our finishing in time.
Looks good. Everyone's content?
Yeah.
Okay.
Yeah.
Okay. Thank you.
Actually, no gradient at all.
No gradient.
That's
No
the best
gradient, which is
diuretic
good.
you can have.
Yeah.
To have an RA pressure of 5, the best diuretic.
That's it.
Mechanical problems need a mechanical fix.
Correct. Fantastic work. Beautiful case. Dr. Sharma, your turn.
Yes. Okay, they're removing now. Everything has been removed and we can go back to our slide presentation.
Final question is lung transplant. Where do you consider lung transplant here?
Oh no, this patient has been evaluated by multiple teams. No, it's not a candidate. Unfortunately.
Yeah. With that age will not be. Okay, let's go back to our slide presentation now. We conclude our didactic discussion. Lot we have already spoken about.
No, I'm doing so.
Okay, so this is the ECG. We have done all that. So now let's go to. Actually, lot has been written now in last few years about the tricuspid valve replacement and the TRISCEND 2 trial and TRILUMINATE,
Are you
both
done,
of them, which got approval in 2024, and the data. So, these are the devices which have been approved by CE mark as well as by the FDA, 2 of them. TTR and TTVR, and annuloplasty and heterotrophic vena cava implant undergoing trial here, but has been approved in Europe. So basically, many data. The question comes is that, of course, you decide TTVR plus TR. So that is where whole question comes down to. The key is if you have more pulmonary hypertension, severe pulmonary hypertension, these devices themselves are contraindicated. But in the large gap, the TTVR will be better compared to TR. And then the whole tricuspid valve field has changed. A nice review article about state-of-the-art paper. And we actually have published also the technique of which I showed about few months ago when we did the Evoque valve, that how to deploy them, TTVR and so by our echocardiographic team. Now these are the 8 valves which are undergoing trials, and of course which had come to the end finish line is the Evoque, but others are still ongoing. And then the Evoque, many trials have shown a small number of cases. Overall, very low complication. And of course, the pacemaker is one of the big issue. Pacemaker, renal insufficiency, as far as effectiveness, works very well. And the TR, of course, at the baseline, the TR, majority of them are a severe tricuspid regurgitation and works very well. So this is actually the one of the algorithm which was just published about, do you have a severe TR, heart team discussion, and if it is a low risk, a patient has a STS of 4 or below, and it's a good case, otherwise could go for the tricuspid valve repair. Very rarely, tricuspid valve intervention is done. With tricuspid, the metal valve, but usually it's a repair is done very well. Otherwise, all have to have optimal medical therapy, reevaluate the severity, and then decision always comes down to which patient goes for TTVR, which patient goes for TR. And that is what we learned. The TR is much safer than TTVR, but is less effective, because leaving 2 to 3 tricuspid regurgitation severity is very not uncommon with a TR, while with a TTVR, usually, or I say almost all the time, 98% of the time, you will have a less than 1% regurgitation. And where it will be more active, you have particularly the issues will be with the lead, bleeding risk, as we mentioned about, and so on and so forth, these cases. So this is actually another representation that where and what you favor TTVR versus you favor TR, and it basically is simple. That is small gap, you go with the TR, large gap, you go with the TTVR, and as we mentioned that if possible, and particularly if the leaflet thickening, there is some gradient, that you go with the TTVR, and otherwise, and there should be no our electrophysiological lead. So this actually, I like it very simple way. You decided now transcatheter intervention is not going to go for surgery. This is very nicely have put together. That's called glide score. Glide score is based on the imaging. And these are the various numbers. You go from 0 to 5 and so, based on how is your annulus, the leaflet, and so, and it turns out to be the low glide score, you go with the TR. The high glide score on 4, you go TTVR. And then, of course, in between, you decide based on the glide score 2 or 3, whether patient, many of them should be referred to the expert centers like here, and of course, the heart team discussion to get to the final result is very essential. And this is the last, the center illustration, the multiple challenges which we have. One is the TTVR challenge in terms of the electrode, lead, conduction, bleeding, and of course, various arrhythmias, and then how to manage them. Management and follow-up, which have been very nicely put together. And many of them, as I said, the pacemaker is the one very important comes into the equation of this. Then the new phenomena, which we knew in the past, HALT, hypoattenuated leaflet thickening and reduced leaflet motion after transcatheter tricuspid valve replacement, TTVR. And this actually seen, the case we already have shown, between the gap between the two layers of the Evoque valve and the thickening of the leaflet. You see that black shadow, and their HALT is defined as HALT 1, HALT 2, HALT 3 with a multiple of 25, 25, 25, 50, 50, 75, more than 75. And all the TTVR have been associated with HALT, and actually it turns out to be not uncommon. 25 to 40% of the TTVR are associated with HALT, and the HALT correlated with reduced leaflet motion and increased transvalvular gradient. Of course, once you have the clot, just like what happened in the aortic valve, and of course those patients are more symptomatic. Then transthoracic echocardiography was insensitive, therefore CT is more accurate. To detect the HALT, it is the CT scan, not the transthoracic. T echo, maybe ICE might be, but that's where we are. Then, very important point they learned, knowing that all cases are getting the antithrombotic therapy. So there was no association between HALT and anticoagulation strategy. So knowing that every patient is being discharged on anticoagulation, still you are seeing 25-40% of the halt. There is no correlation. Now, in our case, I think it was triggered by multiple interruption because of the treatment with the cancer, taking care of the port catheter and so. Now, very important, we all learn just by the in the aortic valve, long-term impact of the halt is not known. Why it is not known? Because this is only done for last 1 to 2 years. We don't have the data. So clearly they say that we do not know whether this halt is going to give rise to a permanent leaflet damage. Now, when we see that halt in the aortic situation, we usually start anticoagulation. Which one you prefer, Anu? When we
Any of the NOVA.
Yeah, but why
Any of
not
the NOVA?
why not warfarin?
No, patients absolutely do not like warfarin because they have to come back for testing. That is one thing about it. And actually in aortic, NOAC has worked well. We do it after 3 months, we will repeat. Like you said, we have to do a CT scan, and often I would say about 70 to 80% respond. And we also have seen, we stop it because then they come back. 50% comes back.
Yeah, we
then
typically
go
start with
lifelong.
DOAC to Dr. Keeney's point because it's safer, it's available, and then if it doesn't work, then we escalate to warfarin. I think that's been our strategy.
But otherwise, it works very well, as just mentioned, and majority of the patient improves the gradient, and if it truly halt. No, sometimes halt may be confused or cannot be differentiated from the valve thickening and degeneration. That is a different story. So it's a degeneration, it's not the halt. But you sudden change in the gradient and patient symptoms, a halt in the aortic valve, and same situation here. Here it is, everybody is on anticoagulation, you're still developing the halt in these patients. And therefore show that very important that halt does occur. And in many of these cases it's causing more gradient, and the CT is more accurate. Now, then study using CTA, imaging post TTVR, that halt after TTVR is common. You see the incidence anywhere from 25 to 40+%, some of them even 70%. Various trials have shown, and the question always comes down to what to do, that we understand this halt, we also cause more symptoms, more gradient, long-term effect we do not know. So very simple, clear, how would you know it? That it is a halt. Patient was doing good, like our case, was getting various, cardiac-wise were good, getting various chemotherapy, changing of the port, and they start having shortness of breath. We right away knew that this patient has developed the halt. So got the echo, got the TE, got the CT, and patient got on the table, and we felt that it will be an ideal case to showcase that this is what we are going to see, some of these patients. Then second issue is the conduction disturbances, which is very, very important in these cases. Almost the 15-17%. New onset conduction occurs in almost like 40+% of cases, but requiring pacemaker in the various studies have shown that it occurs in about 15 to 17%. And what is associated with the subvalvular part of the device in contact with the membranous septum, and then of course if the gradient was high, so higher gradient was associated with the higher pacemaker issues, pacemaker requirement. Evoque, we already said, Transcend 2 trials, which we showed before, no difference in MI and hospitalization, but very effective in terms of quality of life measures and eliminating the tricuspid regurgitation, as you can see there, the black, which is none to trace, and then the light green, so 98+% will be left after using Evoque with the mild or no that TR. As we also said, no difference in the hard endpoints, and the bleeding and the pacemaker are the major issue. The early studies, short term, did not show much in terms of the repeat hospitalization, although this is a very complex wins ratio plot comparing at every aspect of the hierarchical endpoints. So thus the TTVR does decrease the hospitalization. TTVR improves the quality of life, as you can see here, and the 6 minute walk distance. And that actually led to the approval of the device. And as you saw when it came out in the NEJM, there were like 20 letters to the editor. Reason was, truly it was just approved based on little quality of life parameters. So they clearly kept on saying that you are using such an expensive device now and on a very softer endpoint, and FDA has approved it. And of course, the trial data is just because you felt a little better and walk a little more, it was not appropriate. Although now they found out you go to 2 years, there was clear-cut reduction in the heart failure hospitalization. And of course, we know the improvement in the NYHA class and 6-minute walk quite a bit remains. So these are basically the now then question, does it work more in the severe TR or it works more in the massive or torrential TR? So it clearly is. Higher is the TR, better is the effect of the TTVR in those conditions. So this basically showed up to 18 months data, and now we have the 24-month data that it's a significant clinical benefit, but we have to worry about the two safety endpoints. Basically, permanent pacemaker and risk of bleeding. I did not see any embolization in the follow-up. Compared to we see some tower embolization, so nothing was there from that point of view. Triluminate, we all know, and Gilbert all very actively involved, has presented a very aspect of the 2-year data of the Triluminate. We know that also this is the one, heart failure, reduced admission, significant reduction. 1 year was not clear, 2 year clear cut, and then cumulative of function, average number of events per patient clearly was decreased with the device versus control. So Gilbert, tell us, knowing that you are so deeply involved in the trial of the Triluminate, how can we make it like convincing that the TriClip do work in these patients with the severe tricuspid regurgitation?
I think we have to pick the patient selectively. We know now in real world, and everyone agreed that you want to get down to mild TR or less. That's, I think, the new endpoint that everyone agreed on. And if you're not, and if the patient, like you said, can take anticoagulation, I think replacement will probably be a better option, obviously, to the safety endpoint that you mentioned. But I think in real world, as you said, it was presented and published recently, that the pacemaker rate is less. And also, we have new devices coming in the replacement side. Sahil and Lucy are going to be part of the new devices, so I think that makes it even safer.
Let me talk about the new devices. So, there's two main Achilles heel is anticoagulation, the other is RV dysfunction.
Yep.
So these are two challenging aspects of replacement. And there are new devices out there. Yeah, there are new devices out there like the Trisol, which is a washout mechanism, single leaflet, and end-to-end leaflet design. So there's less risk of, okay. So new devices out there that may decrease the need for anticoagulation. For example, the Trisol, I think you can do a short-term anticoagulation, and the Laplace device, which is showing that even in RV dysfunction failure patients, the RV actually improves after fixing TR. So there are different devices which are targeting these mainstay approaches. So I think it's a matter of time before we start selecting patients, not just for repair or replacement, but within the replacement, what would one patient benefit from one device over the other?
And I know Lucy Safi was involved in first one of the tricuspid valve in FIM.
Laplace, transfemoral.
Laplace.
Yeah.
Okay, and they're all coming to America now?
Yes. So the pivotal of Laplace will be IJ to begin with, and then they will extend to TF.
Okay. So basically, that once you follow this is the data from CAR in circulation, that do control group do go down, of course, after some time, because if you take a point of the reintervention, and but if you look at the endpoints, all-cause death and TVI interventions were much higher in the control group, because after 1 year, they were allowed to cross over, and same thing what happened if you take the patients, the crossover or the pure control. So just same thing we learned from the mitral clip trial, the co-op. So once trial is ended, you did the mitral clip, their outcome was similar to what was the original patient. Same way we learned here also, once the trial was done after 1 year, patient could get the clip and outcomes were significantly better, which is the crossover trial on these patients. So this is basically shows here, KCCQ on the top is the device, the lower one is the pure control open, which is the control crossover, and control crossover, as you see, it starts getting towards what the device outcomes will be at 2 years and so. So this basically puts it together, our whole discussion. So I'm just going to complete it, that the transcatheter management of severe TR is on rise. And of course, randomized trial with the 2 devices now, but better understanding with the post-device follow-up, post-market surveillance will improve understanding which device fits where, and the new devices keep coming and so. So most important is the biggest limitation of the TTVR is if patient cannot tolerate NOAC. So that's a very important point, which we had discussion. And then 2 randomized trial basically showing improvement quality of life parameter, better health, more 6-minute walking. And the thirdly is the reduce heart failure hospitalization without on the mortality. So therefore, as we mentioned earlier, that question to know that pre-procedure stabilization. So many of these patients with RV dysfunction and so, if you bring them, you keep them 4 or 5 days, and then you do a TTVR, they increase the length of stay for the hospital. So we spoke to many people, and what many of cases we are doing, they bring the patient, stabilize medically, and then discharge them, let them have a little out of the hospital few days rehabilitation, and then come back for the TTVR. So particularly that you will do in patients who have a RV dysfunction or anybody.
Yeah, so for most patients, remember there are annular sizing issues also, right? These patients come with huge annuli, and what happens is when you optimize them, you realize it's not 56, it's actually 48 or 52. So, you want to optimize them before your workup, and you want to optimize them before the procedure, because you don't want them coming into the procedure room and suddenly you're putting a 52 instead of what would have ideally been a 48. So then once the patient goes home, you realize that was very oversized to begin with.
Okay. Is there any moment to make because few of that, the TTVR were declined by the SAPIEN, by the adverse team, because the tricuspid annulus are too large. Is there a movement going on to make it an even bigger valve?
Yeah, so 56 is their largest valve. What we have done is we put enteroseptal clips on the commissures, and that causes a little annuloplasty, decreases, and we've done it in a couple of cases, and it's been published now. Other sites are also doing it. But the newer valves that are coming out that are with broader range sizes, so you can go up to 170, 180 perimeter in those valves. So there are a lot of new technologies out there. It's a very exciting field.
Okay, so let me go 3 questions. So we finished. We are about 6 minutes over time. The following are the imaging and clinical factors which will favor TTVR or MTR: lower glide score, larger coaptation gap, ability to tolerate oral anticoagulation, and catheter-induced electrical lead related TR. Clearly, the higher the glide score is the one which will tell you to get the TTVR, not that, and the lower one is the TR. Then, statement is true regarding the TRISCEND trial comparing Evoque TTVR versus control at 1 to 2 years, higher bleeding rates with the TTVR, similar reduction in TR severity between 2 groups, higher incidence of permanent pacemaker with TTVR, and significant reduction in heart failure hospitalization. Clearly, it's not the similar reduction in TR. In the control group was about 20-22%, and it was 98% in the TTVR group. So lastly, the following statement is not true about the halt on the tricuspid valve after TTVR. Halt is a common occurrence in up to 25 to 40% of cases. Halt is associated with elevated tricuspid valve gradient. Long-term impact of halt in causing higher MACE is clear, and there is no association with halt and OAC use. So clearly the wrong answer is C, because we do not know what the halt is going to cause, whether higher MACE rate or not. With that, I complete our presentation. Pedro, you can conclude this session now.
Yes. Before concluding, thank you for the audience. You expand on the question of the chest X-rays was related to classical interstitial lung disease from bleomycin. So this is the rationale of the chest X-ray questions. So thank you so much for the team. It's an incredible case, very teaching points, fantastic. As long as this afternoon, you can review it in cclikecases.org. And remember, these cases are presented the second Tuesday of the month, so the next one will be April 14 at 9 a.m. See you then. Thank you so much.
Thank you. Beautiful.
Thank you.